Good morning, everyone. This is Dr. Craig Atkins, and I will be doing this lecture on anesthesia for head and neck surgery. I hope everybody has their running shoes on, as this is going to be a whirlwind tour of head and neck. Most important takeaway from this lecture is that you learn how to safely manage your patient's airway. Difficult airways are most frequently encountered in patients undergoing head and neck surgery. It is not infrequent that these will be challenging airways. You are responsible for keeping your patient safe during the peri-anesthesia period. If you are unable to secure the airway, there may be no surgery, which in the surgery itself could be life-saving. I know this is daunting, but we will get you through it, and that's why we're here to help you. For this course, you will need to know the major anatomical structures of the head and neck. You must be able to identify landmarks such as where the cricoid thyroid membrane is or interscaling muscles. You'll be able to identify various means to secure the airway and list them in order of priority. Given a specific disease, you must tell me a conservative way to secure the airway compared to a more liberal way. Also be able to give me the identified associated risk factors with the surgery based on the disease process. Know each disease, its origin, and its treatment. And if that disease is no longer common, let me know why. Identify the potential causes of airway fires because, as you know, only you can prevent airway fires. When I identify the anesthetic management of specific procedures, I want you to know these are not absolute, but just sort of recommendations. Every facility will be more specific. There are 8 cranial bones. This includes the occipital bone, 2 temporal bones, 2 parietal bones, the sphenoid, the ethmoid, and frontal bones. They are all joined together with sutures. There are 14 facial bones. The vomer, the 2 nasal conchae, 2 nasal bones, 2 maxilla, the mandible, 2 palatine bones, and 2 zygomatic bones, and 2 lacrimal bones. Included with all these structures are 21 foramens in the skull. We are most concerned about 3. The supraorbital foramen, the infraorbital foramen, and the mental foramen. The supraorbital nerve, or branch of the frontal nerves, comes out of the supraorbital foramen. There's a branch of the maxillary nerve that comes out of the infraorbital foramen, and there's a branch of the inferior alveolar nerve that comes out of the mental foramen. Cervical spine, you have 7 cervical spine vertebrae, 2 nerve roots on each side. Please note, as in the picture here where the fracture is at, C3 through 5 is where the phrenic nerve comes off the spinal cord and provides motor innervation to the diaphragm, which is the source of most respiratory muscular function. The phrenic nerve provides the motor and sensory innervation to the diaphragm. The vagus provides the parasympathetic supply for all the organs of the thorax and abdomen. The courses of these 2 nerves are similar. They both start in the neck, run down through the mediastinum, and pass through the diaphragm. The diaphragm contributes to 90% of the resting and quiet breathing. Upon inhalation, the diaphragm contracts and flattens, and the chest cavity enlarges. This contraction creates a vacuum, which pulls air into the lungs. On the reverse, upon exhalation, the diaphragm relaxes and returns to its dome-like shape, and the air is forced out of the lungs. There are lots of major neural and vascular structures that reside in the head and neck. This region is also where most of your senses reside as well: sight, smell, taste, and some touch. I have to laugh. My 9-month-old grandson puts everything in his mouth to explore it. So please note that your orbicularis oculi, this is the site that we often assess with a peripheral nerve stimulator to assess strain of 4. The orbicularis oculi is innervated by the zygomatic and temporal branches of the facial nerve. Of course, that's cranial nerve 7. So we are monitoring the residual paralysis of the facial nerve and associated branches by assessing the function of the orbicularis oculi muscle. The major blood vessels, the carotid internal and external, along with the jugulars, are located lateral to the midline of the neck. The jugular is slightly anterior and lateral to the carotid. The thyroid and cricoid cartilage are midline, protecting the trachea. The thyroid itself lies anterior and inferior to both of these structures. Within the thyroid cartilage lies the voice box or the larynx and vocal cords. Therefore, you should be aware that damage to the neck can increase the risk of airway difficulty. Within the neck, laterally and posterior to the major vessels, lie the brachial plexus. With this picture, please note that the trachea is anterior to the esophagus, which is anterior to the cervical spine. And here the location of the primary sinuses. You have 3 of them: the frontal, the ethmoid, and the maxillary sinus. And notice the location of the primary glands in the face. You have the parotid gland, submandibular gland, and sublingual gland. Now, as we look into the trachea, we'll find the larynx and the vocal cords and the structures. This gives you a good picture. You have the valleculum, which is the area anterior to the epiglottis and slightly superior to the larynx. The epiglottis, of course, protects your pulmonary tree from aspiration. And here you can identify the structures. Again, your epiglottis right here. Your vocal cords right here. And this is the false vocal cords over here. And as you look in the trachea through the vocal cords, you can see the tracheal rings, which are best identified in the lower right on this side over here. And of course you have the cuneiform and the corniculate cartridges, which coincide on these other pictures. The cuneiform are here, 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 here. One of the questions you have to worry and ask yourself when you do an assessment of the patient is, do I need to perform awake intubation? And if this is the case, you have a couple options. You can do a videolaryngoscopy or fiber optic. I must say, in my experience, when we got our we had fiber optics, and we used to do 1 to 2 fiber optics a month in my practice in Kentucky. Once we got the videolaryngoscopy, we did 1 to 2 fiber optics a year because the videolaryngoscopy took care of that. I do believe that videolaryngoscopy is the intubation technique for the future. there's no reason to stick your face in somebody else's face when they can cough on you, and I think COVID has brought that to everybody's attention. When you go to assess the airway, it's really important to figure out whether you can ventilate and if you can intubate. There's an old Air Force saying that says there's no old pilots. There are old pilots and there are bold pilots, but there are no old, bold pilots. There's other issues that you have to think about. Will they bronchospasm when I intubate them? Do I need to pre-treat them with an inhaler, bronchodilator, something like that? Do they have COPD, asthma, chronic bronchitis? When you're rest of your assessment, you need to know what type of blood loss will happen. How do I maintain normal blood pressure if they become hypotensive, and are they frail that it's going to be a real complicated mess? And often with the patients with neck cancers, it is. Do I have the blood products available? Do I have good vascular access? Can I keep the heart rate slow without causing the lungs to contract? Because a lot of these folks are old smokers and they have heart disease and lung disease. Do they have obstructive sleep apnea? Do I need to have them bring CPAP? Will a trach be necessary at the beginning? Can I really get this tube in, or am I going to have to assist the ENT or general surgeon to do that? So there's a lot of risks that you need to assess this patient. Also the risk of fire, you'll have a video on that. And when you do a lot of these head and neck procedures, you're going to be turned away from the surgical procedure so that you may be anywhere from 90 to 180 degrees away from where you have your tube secured. So you have to make sure that you're going to have it safely tucked away so that it doesn't come out during the manipulation by the surgeon. One of the things you talk about when you say, can I ventilate? Talk to the patient and look at them. Do they have a history of a sore throat? Have they had a difficult airway in the past? Do they have prior procedures that may have some restriction of the airway, particularly cancer, or if they've had a neck fusion, such as myself? Watch how they speak to you. The good Lord made us to be symmetrical. Any part of their body that is not asymmetrical should be a red flag. There may be musculoskeletal or neuromuscular pathology. How does the voice sound? Little subtle things like that to make sure that you've got a good game plan. My rule is that you use at least 3 methods to assess the airway and any potential difficulty. There's a 3-3-2 rule, which is 3 finger breaths to your mouth, 3 finger breaths chin, and 2 of the thyromental distance. Here's a picture of the 3-3-2 rule. Mouth opening, 3 finger breaths, tip of the hyoid to the mentum, 3 finger breaths, and 2 to the thyromental distance. Another way to look at it here. If they are less than 5.5 centimeters for thyromental distance, there's a high risk for a potential difficult airway. Again, the intercisor gap, normally it's more than 3 finger breaths. The modified Malampati is slightly different than the Malampati. The original Malampati only had class 1, 2, and 3. The modified has 1, 2, 3, and 4. Typically, you will do the Malampati exam. It's not necessarily correlated with difficult intubation, but we like to think it is. If you open the mouth and have the patient stick out their tongue, you ask them, say, see what you see. Hopefully there's the uvula in the back that more than likely will make it that it's easy. Anything less than that can make it more of a challenging intubation. One of my favorite is the upper lip bite test, and it's much more specific for difficult intubation. There are 3 classes for it. The first one is that you can take your lower lip and put it up over the top of your whole lip in your mouth. The other one is where you can only put part of your lip underneath your lower teeth. And the last one is that you have to put, you can't get your lower lip, your lower teeth up over even your teeth. And class 3 is considered difficult intubation. So this is one of the 3s that I like to use myself. Now this screen is the difficult intubation algorithm that you need to memorize and learn what to do. You know, if you're doing a intubation, are you going to wake them up afterwards? If you can't intubate them, do you even need to go to sleep? You know, I think most people would say that if you're not confident that you can intubate them to begin with, that maybe you shouldn't put them to sleep and you should consider an awake intubation. Needless to say, once you've put somebody to sleep is when you really get fooled more often than not. You almost always think you can intubate somebody. And so at this point, you need to, you know, once you put somebody to sleep, you need to figure out whether you can ventilate them by mask or not. And if you can ventilate them by mask, that's okay. You know, you can do other things if you don't have to have a tube in the throat. But if you do have to have a tube in the throat, then you have to consider what you want to do. You want to wake them up or not. If you can't ventilate them by mask, be prepared to do a cricoid thyrotomy or a tracheostomy on them to secure the airway. Of course, the Carmack-Lehane is just a method used to describe how easy it was to visualize the vocal cords when you went to intubate somebody. And you have 4 grade scales, one being where you can see the cords, the retinoid cartilages, you've got the epiglottis out of the way, all the way to varying degrees, where in 4 all you have is a little bit of the epiglottis. They would say it's not seen, but a little bit of it. You just see it, the back portion of it. So one of the problems with ear, nose, and throat surgery is that you have upper airway obstruction, and that can be more common than not. Somebody that presents with that, you may have to do some sort of insufflation, either through a bronchoscope or through a tube in the back of the mouth. It's often the result of muscle spasms or laryngospasms, as we see. That's another course where we'll talk about how to break laryngospasm. Sometimes you can have edema from croup or epiglottitis. Occasionally you have children or even adults that have swallowed something that's stuck in the back of their throat and obstructing it. You can have somebody aspirate from vomitus or even bleeding, such as with a tonsil. And occasionally you'll have a tumor, but that's less common than the others. There's several options for managing the airway. Of course, we have the direct laryngoscopy, and that assumes that you can visualize and intubate. Video laryngoscopy, which is unfortunately more often reserved for difficult patients, but I think it should be used routinely. And then, of course, the gold standard for difficult intubations has been fiber optic intubation, and it can be done awake or asleep depending on how high risk you think the airway is. Here are 5 common airway disorders. I expect you to know each of them and the management of each one. We have angioedema, acute epiglottitis, retropharyngeal abscess, Ludwig's angina, and tumors and polyps of the airway. Those are the most common of the 5. Angioedema is a rapid form of tissue swelling that is mediated by anomalous activation of the complement system with the release of histamine and other inflammatory mediators. It is usually the result of an allergic reaction. However, there are reports of hereditary angioedema as a variant within the family, and it arises from an autosomal dominant genetic mutation. Complete loss of the airway can occur in severe cases from either form. Just as with anaphylaxis, epinephrine might be life-saving when the cause of the angioedema is allergic, but not when hereditary angioedema. Intubation of the trachea is required in affected patients, and using topical anesthesia while the patient awake or lightly sedated. So the anesthetic management of angioedema, number one, it's going to require intubation more than likely. You're going to sedate the patient very lightly or keep them awake, and you may need to give epinephrine if it is in response to allergic reaction. Here's a picture of it. Scary, I know, but yeah, you can see how swollen her tongue is and how there's very little opening for the mouth. Easily a Malin Potty 4, right? And here's a time-lapse pictures of this gentleman, and you can see the swelling of his lips and then his tongue, and they eventually intubated him. And in the far right side, you can see what his face normally looks like when there's no angioedema going on. The next disease we'll talk about is acute epiglottitis. Epiglottitis is an inflammatory disease of the epiglottis, arytenoids, and arytenoepiglottic fold. It is one of the most dreaded diseases of the airway-related infections, especially as this more than often occurs in the pediatric population. In the past, the victims were usually children 2 to 6 years of age who were often infected with Haemophilus influenza, and frequently this had a tragic result. Symptoms include dysphonia, dyspnea, drooling, and fever. Children often are in a tripod position, supported by their arms slightly leaning forward, head is forward, mouth is open, and you can hear them breathing. I've only seen one of these in my career. It was scary. Chief differential diagnosis in children is laryngotracheal bronchitis, or croup. One of the keys to managing these children is to avoid aggravating them, as this can cause them to cry and create greater respiratory distress. If you're going to put a tube in this child, typically you're going to take the patient back to the operating room, try and keep it as quiet as possible, and let them breathe the gases down and go to sleep. Sevoflurane is typically the drug of choice because that's less irritating to the airway. Could use halothane if that was necessary, but not everybody uses halothanes these days. You're going to maintain adequate respiration, start an IV, and then deepen the anesthesia. Typically a smaller than normal tube is used as there's going to be swelling, which will reduce the tracheal size. Need to have a trach kit immediately available, or a surgeon capable of doing a trach. If the laryngeal airway cannot be obtained, you may need to do something surgically or even do a rigid bronchoscope. Just as a little bit of history, supposedly this is what got George Washington. He said he was bled to death, but apparently had epiglottitis, and they cut him and put the leeches on him to cure the epiglottitis. As you look at this x-ray here, you can see this spot right here. That's the epiglottis. That's called the thumb sign, as it's kind of thickened and swollen. So here are the key points for the anesthetic management of acute epiglottitis. You need to evaluate the child. Try not to cause any undue stress, which can stimulate crying and respiratory issues. You're going to administer an inhalation induction, typically with sevoflurane. Once you get the child deep enough, you're going to start an IV, and hopefully the child won't be responsive to the pain. Intubate the patient with a slightly smaller than normal tube, and be prepared to obtain a surgical airway as needed. Now let's talk a little bit about a retropharyngeal abscess formation. Often this occurs from a bacterial infection of the retropharyngeal space, often seen following a dental or tonsillar surgery. You can see on the diagram to the left that you have the retropharyngeal abscess pushing forward and cramping the space of where the your trachea is, or your posterior pharynx. Right, this area here is being compressed by this tumor here. On the right-hand side, you can see how this looks. It's almost like there's a small golf ball right behind the uvula. If the condition is untreated, the posterior pharynx may advance anteriorly into the oropharynx, as we see. Clinical findings include difficulty swallowing, trismus, and often a fluctuant mass in the back of the throat. So how are you going to manage this patient? You're going to figure out whether you can secure the airway. You might do a direct laryngoscopy, but that may be difficult because there's limited oropharyngeal space and limited mouth opening with the trismus. You also want to make sure that you avoid rupture of the abscess there when you intubate this patient, and always be prepared for a surgical airway, either a tracheostomy or a cricothyrotomy. The third disease we want to talk about is Ludwig's angina. It is a multi-space infection of the floor of the mouth. The infection usually starts with infected mandibular molars and spreads into the submandibular, sublingular, submental, and buccal spaces. This is fairly rapid and aggressive, and as you look at this lady here, you can see that she has limited mouth opening here. And as you look, there's nothing to be seen. Obviously a class 4 Mallampati. Often these folks will be drooling, they'll have significant dysphagia, and oftentimes they'll be sticking their tongue out just to maintain their airway. Anesthetic management for this will be similar to the retropharyngeal, depends on the severity of the disease. Often you'll do a fiber optic if you don't think you can do a direct laryngoscopy or a video laryngoscopy. Typically this is done awake with localization and minimal sedation. Remember, all sedation decreases the amount of respiratory rate, and therefore you don't want them to get too sleepy and quit breathing when you need them to breathe on their own. And you always need to be ready to do a surgical airway. Typically, tracheostomy is the standby or the go-to surgical procedure for this. Another picture here I want you to look at. Again, it's a rapidly progressive cellulitis of the sublingular and submandibular spaces. It's often life-threatening, and it's usually just the common Staph aureus or Staph viridans. Okay, let's talk about airway tumors, polyps, and granulomas. When I was a student, I found a big airway tumor when I went to intubate somebody, and it was incidental to the procedure that they were having. They were having another procedure done at the time. As you can see on the screen here, I'll try and draw a couple pictures. These are the polyps here. The vocal cords are along here. And I don't think those are the true cords. Those are probably the vocal folds. But one of the most common seen and common procedures that you will do with head and neck surgery is laryngeal papillomatosis. Again, you can see the tumors right here in the middle, vocal cords, or at least false vocal cords along here. And you actually see some of the tracheal rings down here. A better picture, which I don't know why they flipped it upside down. This is the anterior commissure on the bottom of the left-hand picture. This is the anterior commissure right here on the top of this picture. So they've kind of flipped. So as you look at this tumor right here, it would be located right here on this picture. So it's kind of upside down, but that's okay. Another example of a very large tumor here. You can see how this is probably going to cause some stridor and problems. Again, vocal cord here, here, maybe a retinoids down here. It's hard to tell because the picture gets a little dark there, and you can see that there's a risk that when you intubate these patients, you can fold the tumor in on itself so that it actually falls into the larynx and occludes if you're not careful. So anesthetic management of laryngeal papillomatosis, you're going to want to secure the airway as always. There may be some stenosis that are present. Often these patients come back for multiple procedures. You may get to know them if you're working at a place that does it frequently. Always be prepared that the tumor may obstruct the airway, or you may obstruct the airway with the tumor by pushing it into the trachea. Typically, you'll use a smaller than normal tube, and often it's going to be a laser tube or a tube wrapped in foil to divert the laser beam. The standard of practice now is just to laser beam these tumors off and take them out. Usually doesn't take too long. One of the concerns is that they can have a little bit of tracheal malacia, and this can result in airway collapse after extubation. Okay, let's talk about pandoscopies and what we do as anesthetics for them. Panoscopies are where we're using endoscopic equipment to look at more than one location. So when we do ENT, sometimes they'll do a rhinoscopy, a nasopharyngoscopy, and a direct laryngoscopy. Typically, we're talking about in the ENT version, nasopharyngealoscopy, direct laryngoscopy, and bronchoscopy. Oftentimes, a pandoscopy is also referred to in the GI clinic, and that would be esophagoscopy, gastroscopy, and duodenoscopy. As we just spoke about laryngeal polyps, direct laryngoscopy is used to search and identify laryngeal, pharyngeal, and tracheal tumors and potentially resect or ablate them. Please notice the small tube outside of the patient's mouth. This is often required to maximize visualization of the larynx. Also, you may use intermittent jet ventilation to ventilate these patients. The thought is if the tumor is superior to the cords, you can use an endotracheal tube. If not, it won't be a direct laryngoscopy, it'll be a bronchoscopy, and you can ventilate through the bronch tube. Often if they're trying to confirm whether the patient has cancer or not, they will not initially use a laser. And this is because the laser destroys the tissue, and it's tough for the pathologist to give them a diagnosis with any degree of certainty of this tissue that's been burnt. These patients are often positioned with their neck flexed and head extended with a shoulder roll. This is a picture of the anterior commissure laryngoscopy. It will be used in a fixed position, often with a microscope. It's designed so that the laryngoscopy will be held in place with the support positioned on the chest or on a device such as a Mayo table stand across the patient. Either way, it needs to be padded real well. So if the surgeon decides to use a bronchoscopy, it can be either flexible or rigid. And by flexible, I mean the fiber optic bronchoscope that we all have used, similar as we have used in the simulation lab. When we use the rigid bronchoscope, which is the picture on the right, often you can attach your circuit to the bronchoscope and ventilate in between procedures, the surgeon will often be biopsying a tumor, and he doesn't want you ventilating the patient while he's trying to biopsy. So you'll have to coordinate with the surgeon on your ventilation aspects. Sometimes you'll use a flush or jet ventilation for these type of procedures as well. Typically, the rigid bronchoscope is going to require a general anesthetic. The flexible bronchoscope, on the other hand, can be done under sedation or deep sedation. Sometimes it's under a general anesthetic, but it can be done under sedation as well. And again, you'll have to coordinate that with your proceduralist that's performing. Here are some tips for managing the patient for pan-endoscopy. Most of the time, these procedures will be done under general anesthesia. This can be done with total intravenous anesthesia or inhalation anesthesia. Again, you will have to coordinate this with your surgeon to provide the best operating field possible. Obviously, if they need the patient paralyzed, it's going to have to be a different situation than if they don't need them paralyzed or the breathing on their own. Sometimes the flexible bronchoscopies can be done with sedation. Always consider the airway. This is what got Joan Rivers, as they did a biopsy of her larynx, and she went into laryngospasm, and they didn't have any muscle relaxant at the facility, and they were unable to break the laryngospasm and didn't have the capability or didn't successfully trach or perform a cricoid thyrotomy. But your endotracheal tube is going to be small, what they consider a microlaryngeal tube. Often you'll need to do jet ventilation, and you may use a combined method of intermittent, put a subglottic airway in and do some jet ventilation. Again, each facility is unique how they like to do this. You'll have to coordinate this with the surgeon that is performing the operation. If push came to shove, sometimes you do this under tracheostomy. People already have polyps in place and they have a trach, so you'll just use that. That makes it easy if that's the case. Sometimes you've had to do transtracheal jet ventilation to maintain the airway on these patients. But most of the time it can be done either with a small microlaryngeal tube or jet ventilation. Typically, if you're going to use the intravenous method, propofol, remifentanil, and a neuromuscular blocking agent, ketamine is real popular. Sometimes you can do ketamine and Versed for just a deep sedation procedure as well. Often, if you're going to use inhalation, you want to use sevoflurane, some short-acting narcotic, and probably a muscular blocking agent. This is really convenient now given the advent of Sugamadex, which allows you to reverse these muscle relaxants really quickly. As I mentioned, Joan Rivers, let's take a moment to reflect on her tragic death. This is a picture of her with her daughter, Melissa. Joan Rivers died from anesthetic mismanagement of her airway. While most of you are too young to remember her, ask your parents. They will. As just an aside, some have speculated that the current TV show, The Marvelous Miss Maisel, is modeled after her life. I don't know. But I digress. She is a classic case regarding airway mismanagement and head and neck surgery. Her story is as such. She went to the GI Center for a routine EGD. While the EGD was being performed, they discovered a polyp on her vocal cords. Now, the facility was not credentialed for ENT surgery, just GI procedures. But the surgeon took it upon himself to biopsy the vocal cords, primarily as a convenience to her. You know, he didn't want to have her come back another day to have this done or to another facility. And the other side of this is that 80-year-olds are not the healthiest. So he's trying to do her a favor, but in fact ended up being part of the cause of her death. While all details have not been released, it has been confirmed that they were unable to ventilate, unable to intubate, and this resulted in brain injury and death to Mrs. Rivers. I have a pretty good idea of what went wrong, knowing what I know about anesthesia and surgeries. When you biopsy the vocal cords, you need to be cautious because they will spasm very readily. They are trying to protect your airway. I am confident this is what's happened. Most GI facilities are hesitant to keep any muscle relaxants or any short-acting muscle relaxants available. Succinylcholine, you need to have dantrolene available if you're going to use succinylcholine. So many surgery centers do not carry succinylcholine, as dantrolene is very expensive and it typically expires before you use it. Anyhow, her vocal cords paralyzed. Being 80, she probably didn't have the healthiest heart and lungs. I think she was a smoker at one time. They were unable to intubate, unable to confidently perform a cricoid thyrotomy or tracheostomy, or didn't have the capabilities to do those, or transtracheal jet ventilation. Hypoxia and hypercapnia ensued. She probably had a cardiac arrest. The anoxia eventually led to the relaxation of the vocal cords. They were able to intubate her at this point, but that was not after several minutes of CPR. She was transferred to the hospital and expired within the next few days. I want to note that this was not a CRNA that performed this anesthetic. This was an anesthesiologist. Please remember that the enemy of good is better. And there are many people that have gone into the hospitals that have had someone trying to do them a favor that has ended up being a complication. And my father was one of those. Mismanagement of the airway, you are responsible for securing the airway, making it safe for the patient one way or the other. Sometimes you have to protect the patient from the surgeon. Often the really big procedures in anesthesia for head and neck surgery are those patients with head and neck cancer. Typically, this is 5% of all cancers, usually men over the age of 50 with a history of smoking and alcohol abuse. Often these will metastasize to other parts of the body. And these are what you're really looking for when you do these direct laryngoscopies and bronchoscopies. Patients often complain of, with symptoms of hoarseness or stridor, hemoptysis, ulcers in their throat that do not heal. And this can be anywhere from glandular, such as tonsillar cancer. I once had a young lady who had tonsil cancer at the age of 18 and then at 31 had a reoccurrence. Again, I'll say it was tragic because she had been seeing her cancer specialist for almost 5 years, complaining about sores in her throat. Finally went to an ENT doctor. We did a biopsy and it was a recurrence of her cancer. And her prior physician had refused to allow her to have any of these biopsies because he kept saying that it couldn't be cancer, it couldn't have recurred. So always have a high level of suspicion when everybody gives you symptoms. Don't just blow them off. Neck dissection is commonly performed in isolation or during laryngectomy to prevent or treat any local spread of head and neck malignancy. The extent of a neck dissection operation is based on the extent to which the neck's 6 node levels are involved, as well as the extent to which additional structures are removed. These additional structures include the spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. Depending on the degree to which the tumor can be removed safely and prevent the recurrence or spread, as well as to the extent that phonation and swallowing can be preserved, various surgical options are exercised. Sometimes disease is managed by radiation or laser therapy or microsurgery or even partial laryngectomy. The advantages to these is that it preserves organ function and phonation. Often these patients will have tracheostomies either at the beginning or after the procedure. Neck dissections are a procedure that you'll see at many hospitals, particularly the larger ones. Typical anesthetic management for these patients involve you're going to do a general anesthetic with standard ERAS protocols. Typically, it'll be a routine intravenous induction. You'll secure secondary IVs and arterial lines after you get the patient to sleep. Often, you'll want to monitor nerve function. They have special endotracheal tubes, and so you may need to limit your neuromuscular blockade. And again, you'll need to coordinate with your surgeon if you're going to need to do a tracheostomy or not. Typically, that is done at the beginning of the case to make everything easier. And often you'll put in a wired tube to make it fairly, quote, kink-proof and help get you out of the way of the surgeon. With these tubes, always with all tracheostomies, be aware that there can be accidental extubation when moving the patients. And often you're going to transport this patient directly to the ICU, and they'll be on the vent. And oftentimes you'll have to manage the ventilator settings in the post-op period, so you just need to be aware and ready to do that. Motor vehicle accidents are a major cause of facial and ENT fractures. However, personal altercations can result in them as well. Anesthetic management for otolaryngology trauma is similar to others. The principal focus is to secure the airway safely, and oftentimes this will be a nasal intubation. Sometimes it will be performed asleep, sometimes it'll be performed awake. It's really dependent upon how stable the airway is. On the screen, I've given you an example of a few different types of trauma that are frequently seen. Mandibular fracture, maxillofacial fracture, zygoma fracture. You can even see laryngeal fracture, but typically the nasal fracture, these are all high velocity trauma incidents. Tonsillectomies and adenoidectomies are one of the most common surgeries in children. As you look at these pictures, please note the decreased oropharyngeal room in the back of the throat. This has the kids presenting with significant snoring at night and often having to sleep with their head up in order to maintain their airway. The tonsils are at the back of the throat and they're lymphoid tissue. The adenoids are a mass of lymphoid tissue located posterior to the nasal cavity and the roof of the nasal pharynx. These tissues can become hyperplastic and obstruct the nasopharyngeal airway. A number of problems can occur that the adenoids require removal. Often the tonsils are taken as well. Another indications for tonsillectomy include tonsillar hypoplasia, chronic tonsillitis, and malignancy, as we discussed earlier. These chronic obstruction can lead to obstructive sleep apnea, which leads to other comorbidities such as cardiac problems. Here are pictures of the tonsillectomy before and after. I'm not sure how many of you have been in the operating room, so try and, when you get to the OR, try and observe as much, do your anesthesia, but also try and observe as much of the surgery, because then it'll help you anticipate the needs of the surgeon and the length of the surgery. So the top picture is, these are all three pictures of the same patient. The top picture obviously is the before tonsillectomy. and you can see how the tonsils have all but completely obstructed the oral pharynx. The middle picture is immediately after the surgery. Typically, this is done, they can do it with a laser now or with a cautery device. The tonsils, because they're lymphoid tissue, are fairly encapsulated, so they kind of come out like marbles out of the back of the throat. Not exactly like that, but somewhat. And then the picture at the bottom is a few days post-op, maybe a week later. You can see that there's substantial swelling of the uvula, that there's healing in the posterior pharynx where the tonsils were at. This, while maybe a minor procedure for children, is a real major procedure for adults because swallowing becomes a huge problem with this much of a sore throat. It's often hard to keep them hydrated. My son was, I want to say, 10 years old or 11, and he had chronic tonsillitis, and it was obstructing his airway. And he didn't talk for about 3 or 4 days, and he had a little pad, and he wrote notes to me and my wife. And one of the notes he wrote her was, "Am I going to die?" And we told him no. But that's always a fear, particularly of children. Anesthetic management of tonsillectomy and endoidectomies are fairly similar to most anesthetic managements. It depends on the age of the person having the procedure done. Adults are going to give a standard IV induction. Children, you'll probably do an inhalation induction depending upon the age. Often you'll use a specialized tube for the airway, either an oral ray or a wire reinforced tube. Again, it will be age appropriate. It will either be taped to midline or off to the side. Again, you'll have to coordinate this with your surgeon. Many times it is an uncuffed tube in children, and so they will be using a packing in the back of the throat to keep blood from getting into the stomach. It's important before you extubate the patient to make sure that the surgeon has removed the packing. I cannot tell you how many times that I've been involved where that has not occurred, and you just need to have them come back and take it out. I have also had my tube, because a lot of times they are secured without tape, but so the surgeon can move them at their will. You have to be very cautious that they don't extubate the patient. Now, the ENT physicians are very comfortable as a rule for reintubating the patient should that occur while they're doing the procedure. But you also need to be careful of the staff in the room. My very first pediatric ENT case that I did, the scrub tech whipped the Mayo stand, which is where they secured the retractor for the ENT surgery on, and they had taken everything down. But when she moved the stand, she caught my circuit and extubated my patient before I had a chance to do anything. Literally in just a matter of seconds. So I did a deep extubation, which sometimes you will do for these patients, but it was fairly harrowing for me. The patient did fine, but that's just one of the things you have to be concerned about when you extubate these patients. And when post-operatively, they can have some bleeding, and this usually occurs within 6 hours. And they can also have laryngospasm. So you need to be cautious with these throat surgery patients that either they're real deeply asleep when you extubate them, or they're wide awake that they won't have laryngospasm. When we talk about nasal surgery, there's multiple types of nasal surgery. People can have external procedures, maybe a septoplasty. That's more internal, but it's fairly superficial. They'll have procedures within the nasal sinus cavity. This is typically done with an endoscopic device, also known as a FESS, F-E-S-S, functional endoscopic sinus surgery. You can remove polyps, get rid of infected membranes or cysts that may be there for people who have had chronic infections. If somebody has facial trauma, they may have broken bones in the nose, and they can do some procedures to straighten the nose, reconstruct the nose, and or remove turbinates that may be swollen and inflamed. So when we talk about nasal surgery, one of the most frequent ones discussed is the rhinoplasty, which is a reconstruction of nasal bone structure. Typically, they will fracture the bone, remove some of it, and reshape it into the image that has been chosen by the patient and the doctor for their optimal viewing pleasure. You can see the picture on the bottom left. This young lady had a large nasal hump that was removed, and she had a reconstruction of her nose. The top two pictures are both pictures of nasal polypectomies. Often they are done with endoscopic surgery. That's why you see this little round circle there. That's a picture taken through an endoscopy scope, and they are going to remove those polyps. It's easy to do. Sometimes they'll do some sinus surgery, more or less. Most of it is done by endoscopic these days, but there is some that's done more directly. The bottom right picture is a septoplasty, showing the results of it. You can see the picture on the left, from the bottom right. There's two pictures, one on the right, one on the left. The one on the left has the cartilage that is not straight, and you have the turbinates combined with the cartilage obstruct the nasal passage. Often they'll do what's called an out fracture of the turbinates when they do a septoplasty, so they kind of smash the turbinates up against the wall of the nose, and that helps open it up. And you can see that the nose now will, there's a lot better space for breathing. So as we talk about anesthesia for external procedures of the nose, again, I want to reemphasize the role of the anesthesia provider to protect the airway of the patient. A lot of these procedures will be done under local or deep sedation. Many of them will be done under general anesthesia. But regardless, you have to make sure that the patient is awake at the end of the case so that they can, if they do have any vomit or if they have anything that gets on their cords, they can get it expelled. Typically, you're going to do a general anesthesia. ENT surgeons like to use local, so they're going to use lots of local, probably sometimes with a little bit of epi, so you might see an increase in heart rate as well. Often, you can manage these patients with a subglottic. Occasionally, you can manage the patient with a subglottic airway, but more often than not, you're going to use an oral ray tube, depending on the surgeon, the facility preference, and what's available. As with tonsillar surgery, there's often an oropharynx packing that needs to be removed, as well as some nasal packing. And if they're going to do bony or cartilage structure repair to the nose, you're not going to be able to put any pressure of a mask on the nose and not cause problems. And that's why you need to have the patient awake at the end of the case so that they can be breathing on their own, which why, you know, with the new drugs, Sugamadex and some of the other things that we have, propofol, it's good. You want to gently wake the patient up, minimize coughing, and avoid pressure, as we mentioned, on the nose. And this is just to give you a picture of what the nasal endoscopy will look like. Typically, whenever they do a rhinoplasty or a septoplasty, they will be doing some sort of endoscopic evaluation of how well everything looks. It varies from physician to physician. This is how they'll also do some of the sinus surgery, whether it's maxillary or ethmoid sinuses. Endoscopic sinus surgery is a real common procedure performed mostly in the surgery centers, occasionally at the hospital, but most of this is done in surgery centers. There are various indications for it, such as nasal polyps, recurrent or chronic sinusitis, control of bleeding, removal of a tumor. You may need to decompress the orbit, secondary to tumors or foreign bodies, whatever. And often you'll have, particularly in children, foreign body removals, P's, whatever, a whole variety of things that can end up being pushed up noses. They can have mucocils and other things of the like. And this young lady doesn't appear to have an endotracheal tube in, so I assume it's local. Her eyes aren't taped or anything. When you're doing this type of procedure, you need to consider whether it's going to be local, general, or a combination. Again, are you going to do, if it's general, are you going to put an ET tube in or a subglottic airway? The nice advantage of the subglottic airway is it's less stimulating, but it's more likely to be displaced. You're going to have to decide whether you want to do an inhalation or a balanced technique. The physicians, ENT doctors also like to use a lot of cocaine because of its vasoconstricting properties as well as its local properties. So blood pressure control can be an issue. They're also going to probably use some local with epi just to minimize the bleeding. When you look in an endoscopy, if you've got a chance to do a fiber optic bronch, you know any secretions include the visualization. And the same thing for these surgeons with doing a functional endoscopic sinus surgery. If you have to control the blood pressure, again, it depends on the patient. You may be able to use beta blockers. You may have to use something else if they have reactive airway disease. Most of this is going to be at the surgeon's and the anesthetist's preference. When I first went to work in northern Colorado, in Fort Collins, Colorado, I worked with a surgeon named Dr. Stan Henson, and he was a very fascinating guy. He was an Olympic wrestler in the late 30s because the Olympics were canceled because they were held in Germany. He was a faculty at the U.S. Naval Academy, so he went to war during World War II, came back from World War II, then went to medical school. And he was the first surgeon in the town of Fort Collins. He'd done research on thyroid and parathyroid cancer, and he was actually one of the regional experts on parathyroid removal. So anyhow, Dr. Henson at this point was getting quite elderly, and one day he was down in the cafeteria, and there's this lady working as a cashier in the cafeteria, and he noticed a lump in her throat. And he said, you know who I am. I'm Dr. Henson. Let me evaluate this lump. And they ended up taking the thyroid out, and she had thyroid cancer. And he actually just found this lady's thyroid cancer while he was getting food in the cafeteria. And the reason I mention that is that it's important for us as anesthesia providers to always be alert and always looking at anatomy and identifying what may be abnormal for the patient's benefit, and maybe also just to keep herself out of trouble. In this picture, you can see the lump in this lady's neck. It's on the left side, and that's obviously a thyroid enlargement. So what are indications for thyroid and parathyroid surgery? These procedures are almost always elective, as there's often a medical management component that is available to treat these diseases. And if that fails, that's one of the indications for a thyroidectomy or parathyroidectomy. Sometimes managing the hypercalcemia associated with parathyroid disease is not an option, and so the only way to treat it is to remove the parathyroid glands. Often they'll leave a portion of the gland in place to help regulate the calcium. Often you'll also have tumors that are benign of the parathyroid glands. But you need a little bit of parathyroid hormone just to regulate your calcium. There's a variety of ways to do it, and each surgeon's a little bit different. As we mentioned before, thyroid cancer and a symptomatic thyroid goiter. One precaution with all these patients and tumors in the neck is that they can compress the trachea and may make intubation difficulty, so proper assessment is important. Complications of these surgeries include hematoma, vocal cord dysfunction, and hypocalcemia. They will monitor the calcium levels extensively immediately in the postoperative period for those having parathyroid removal. The thyroid gland has two lobes and an isthmus. The lobes are located slightly lateral of the midline of the neck, anterior to the larynx. Each thyroid lobe has 2 parathyroid glands. Note the location of the thyroid to the arteries and the cricoid thyroid membrane. The right recurrent laryngeal nerve originates from the descending right vagus nerve as it passes intermediate to the right subclavian vein anteriorly and the right subclavian artery posteriorly. It curves posteriorly around the inferior margins of the right subclavian artery. Then it passes medially and descends over the posterior lateral surface of the trachea into the groove between the esophagus and trachea. The left recurrent laryngeal nerve originates from the left vagus as it passes over the arch of the aorta inferior to the left superior intercostal vein. It passes medially and posteriorly deep to the ligament arteriosum before curving inferior to the arch of the aorta. It then passes superiorly over the left main bronchus to ascend in the groove between the left side of the trachea and the anterior of the esophagus. These nerves, which are branches of the vagus, innervate the larynx and the pharynx. So you might ask, why is this important? This is because the recurrent laryngeal nerve, it has motor control of all the intrinsic muscles of the larynx. The thyroid arytenoid, the posterior and lateral cricoid arytenoid, and the arytenoid muscles depend upon the recurrent laryngeal nerve. It also transmits sensory information from the mucous membranes of the larynx from the lower surface of the vocal fold downward. Injury to this nerve may impair or restrict phonation or breathing. Here's another picture of a lady with a large thyroid tumor, and you can see by the size of it and just looking anteriorly that there's some displacement of the trachea to her left side. This will be important as you do a direct or a video laryngoscopy on this lady to realize that the trachea is going to be off midline, and you'll have to look for it a little bit. Sometimes you do awake intubations on these people because the trachea is so compressed that it actually collapses entirely once you induce the patient. You'll have to evaluate this, and your surgeon should have a good idea as well as your evaluation of the patient. Today, often during thyroid or parathyroid surgery, due to the location of the recurrent laryngeal nerve and how devastating an injury to that nerve can be to the patient, what has come into play is nerve integrity monitoring. And this is an example of one of the many monitors that are available, or the tube anyway. The endotracheal tube actually has an electrode on it that allows for this monitoring. It needs to be placed in the correct positioning in the larynx to get the most accurate monitoring. It's accuracy dependent upon tube placement, and also there must be a dry field. If there's too much bleeding in the field or too much moisture in the field, it can not allow the current to be processed correctly. The diagram on the left addresses the issue of correct tube placement. You can see that it's typical placement of the endotracheal tube with the idea that the electrodes need to be in contact with the cartilaginous component of the trachea. And as you look at part A of that diagram, the little dots inside the cords represent the electrodes that are in place to help identify where the recurrent laryngeal nerve might be located. And remember, there's a right side and a left side. The picture on the right kind of displays how this all works. There's a signal that is sent to the vagus nerve the entire time, and the operating surgeon has a handheld probe while they're intermittently stimulate to make sure that the nerve is functioning correctly. In the preoperative evaluation of the patient with thyroid disease, you want to, primarily you're going to be looking for hyperthyroidism, and typically these will be protrusion of the eyes, some nervousness, maybe a history of insomnia, a little bit of hair loss. They may have some more moist skin. The goiter may or may not be enlarged, and you may have a rapid heart rate with also a resting tremble. You kind of want to get all of this under control prior to the surgery so that you're not dealing, especially with the problems with the tachycardia during the case. Also, while you're positioning the patient, if they do have some exophthalmos, make sure you pad the eyes really well and protect them, because you'll be away from that area for the most part of the procedure. And along with a thorough preoperative evaluation includes looking at the neck for any potential deviation of the trachea secondary to the thyroid mass. This X-ray demonstrates significant tracheal deviation with retrosternal enlargement. When you have these type of patients, be prepared for difficult intubation. Consider a video laryngoscopy or maybe even a fiber optic awake intubation. It depends on how well the patient is managing their airway with the enlargement. With these patients, if the thyroid is not well under control, you may have hypertension and tachycardia, and you want to try and get those under control prior to the anesthetic. You'll have to choose whether you want to do an inhalation or a TIVA anesthetic. You can do a combination of them. Typically, propofol is used for induction and a shorter-acting neuromuscular blocking drug for intubation. This is because if you want to use a neural integrity monitor on the ET tube, you're going to want that the blocking agent to go away fairly quickly. Another consideration during induction is the dexmedetomidine to help with the pain and help be more cardiovascular stable. Remember, as you position the patient with a neck roll, that you will extend the neck, and by doing that, you basically push the ET tube more distal, so you could end up with a right main stem intubation. So whenever you get the position or you get a patient with a neck roll, be sure and recheck the breath sounds to make sure that your tube's not too far. Often you'll have the tube that is away from the surgical site, so you have to secure that and take any pressure off the head of the patient. When you're concerned about blood loss, if you hear the suction activating a lot, that lets you know, that's a clue that there's a lot of bleeding going on. Hemorrhage can be a post-op complication, and patients return to the operating room with neck hematoma may have compromised airways. Post-operative complications includes all of the listed. You'll look for swelling in the neck, any sort of hoarseness, difficulty speaking, perioral tingling, neuromuscular twitch, seizure can indicate a variety of these complications. So have a high index of suspicion. Typically, these patients don't have airway issues, but they may have some difficulty opening their mouth. The anesthetic management for these patients are fairly similar to other types of procedures. You'll just want to make sure that there's not extensive bleeding or nerve injury, which could create some numbness of the face primarily when you extubate these patients. I have a whole video on airway fires that I have you watching. I think it's very important. Fires, whether you start one in your campsite or in your fireplace, require certain essential elements. They need some sort of fuel, they need an oxidizer, and they need something that will ignite those fires. Typically, the fuels are applied by the nurse, such as a PrEP solution. The anesthesia provider provides the oxygen, which helps oxidize that, and the surgeon is using an electrocautery unit or even a laser that causes the ignition. It's important because a lot of the OR fires occur in head and neck surgery, and so it's important you understand the implications of that. I have an Anesthesia Patient Safety Foundation video that covers the material better than I can, so please watch that. So the question becomes, how do we prevent fires? One thing is we need to wait for the prep to thoroughly dry so that it's not moist anymore. We want to limit the amount of oxygen that is in an open space. Also, we want to use tubes that will not burn. You can see the picture on the left demonstrates how the PVC tube, once ignited and has oxygen flows, looks like a jet fire of some sort. Often you'll put water in the cuff to minimize the risk of fire. The laser tube on the right has a metal wrapping around it, and it reflects the laser beam, and it has two cuffs to minimize. If one gets perforated, you still got another one to secure the airway. We're talking about head and neck procedures. We need to talk about ear surgery. Usually this is associated with pediatric. Occasionally you'll do adult surgeries, but most of it is pediatrics. Typically you'll have a foreign body removal. A child has put a pea or something in their ear. Occasionally you may have the external ear, some cartilage removed, or if they had ears that stuck out quite a bit, they might be moved where they're closer back to the side of the head. So typically, laryngotomies, tympanoplasties, and the like are often what you see for ear surgeries. A more complex is a cochlear implantation, and that occasionally is done at the bigger institutions. Bilateral laryngotomies is just the laceration of the eardrum to let the fluid out. When they call it BMT, which is bilateral laryngotomy with tubes, that's a picture on the right-hand side of it of tube being put in after the laryngotomy. This is one of the most common ear surgeries, and it's mostly done in children. It's quick and easy. Typically, you will do an inhalation induction on a child. Once they're asleep, you'll start the IV. If needed, the surgeon will lance the eardrum or the tympanotomy and insert a tube, and at that point, you just turn the gas off and they wake up. There's more time spent getting the patient asleep and awake than the surgery itself. A mastoidectomy is a little bit longer procedure, and basically they're going to go behind the ear and take out all the disease cells that are in the mastoid bone. Typically this is people that have a history of chronic ear infection, and they're doing this to keep it from eroding and become a cerebral type infection as well. Again, usually this is children. It's a more long and involved procedure. Just some general considerations for ear surgeries. Some procedures can be done without general anesthesia, but most of them require it. I doubt that you can do a local procedure on a child, and I wouldn't recommend it, but some of the adult procedures can be done with local. The airway needs to be secured with a device that will not kink with manipulation of the head, most likely an ET tube, but some people are using supraglottic airways. Many inner ear procedures will have nitrous omitted because this diffuses from the blood into the inner ear and can cause changes with the reconstructive surgery. Basically, the inner ear becomes a closed space when they put the tympanoplasty over the hole in the eardrum, and the nitrous infuses out of the blood and create pressure in there and potentially push the graft away so it doesn't heal. You need to check with the surgeon because there are new types of procedures where actually they want you to use the nitrous because that pressure helps seal up the procedure that they've done. Oftentimes you need to avoid paralyzing agents. Children have a high incidence of nausea and vomiting with manipulation of the ear, and so you're probably going to, if you get an IV, you're going to need to give them something to help post-operatively with that. Again, parotid and other salivary gland surgery is very similar to other anesthetics. Basically, you need to be concerned of whether they've had some previous radiation or not, and if there's some compromise of the airway, you need to observe for any displacement of the airway, do a good oral airway assessment, and you may need to avoid any neuromuscular blocking drugs. You'll find that a lot of people that have sleep apnea are looking for a quick fix, and there may not be that quick fix, but surgeons are more than happy to offer them a procedure, and it's called a uvulopalatopharyngoplasty, and it's occasionally effective. And basically you remove all the tissue, the posterior, the soft palate, to create more space in the back of the throat. Usually a not long-term effect from this surgery. This is what I did my doctoral work on, with sleep apnea, and the only real way to typically help with sleep apnea is to lose weight, and just removing tissue is not effective, but people will pay to have that done. Zinker's diverticulum is an infrequent diagnosis. It was first described in 1874 by Dr. Zinker. It is a herniation or an outpouching of the pharyngeal mucosa through the posterior wall of the hypopharynx. It occurs typically in those 60 to 90 years old, and the incidence is about 1 in 800 when we do barium swallows. A couple different ways to fix this. It can be done endoscopically or with an open transcervical approach, which is the only way I've seen it done. They either excise the diverticulum or tack it superiorly to the prevertebral fascia. Those seem to work as well. Occasionally a cricoid pharyngeal myotomy may be added. In the endoscopic approach, no skin incision is required. Here, the surgical procedure usually involves ablating the common wall between the pouch and the cervical esophagus by using an endoscopic stapler or a surgical laser, possibly. So what are the anesthetic considerations with a Zinker diverticulum? Typically, these are your older population, so they have the usual suspect comorbidities, heart and lung disease. With the pouch, there's an increased risk for aspiration. So typically these patients will be induced with a rapid sequence induction. You definitely don't want to just place a blind NG tube, as it may inadvertently go in the pouch and perforate the pouch. Typically you'll do other types of block, local and cervical and deep superficial cervical plexus blocks. Remember, as you're working in this area, in close proximity are the carotid baroreceptors, and any pressure on there may elicit a bradycardia. As in most cases, you're going to want to avoid a traumatic wake-up so that it's a smooth and no coughing. Well, let's talk a little bit about some surgical airways that we may come across. Typically, we're talking about a cricoid thyrotomy or a tracheostomy. The cricoid thyrotomy is almost always emergent. The tracheostomy tends to be fairly elective. And you can see the red line here in the middle that's flashing on the screen. That is the cricoid ligament. It is just inferior to the thyroid cartilages and superior to the cricoid cartilage. This is done to secure the airway by a surgical means if need be. There are numerous differences between a cricoid thyrotomy and a tracheostomy. Typically, the tracheostomy tends to be more permanent procedure than a cricoid thyrotomy. Usually the cricoid thyrotomy is more urgent, and it's only a temporary access. Typically, you're not going to sedate these patients, whereas in a tracheostomy, often it's done under general anesthesia. If the patient's too sick, it can be done under local with light sedation, but typically it's a general anesthesia. Cricoid thyrotomies are not often done in children. It's relatively simple to do. The tracheostomy is a much more complicated procedure. And if you have somebody who has an upper airway mass, the tracheostomy is a little bit lower down in the trachea than the cricoid thyrotomy. Typically avoids that. If speed's of a concern, you want to go with a cricoid thyrotomy. If you have to do a cricoid thyrotomy, basically you're going to insert a cannula through the cricoid thyroid membrane at the midline level, and you'll use a source of oxygen that can inflate the chest, typically 50 psi. You can generate that most of the time with a wall meter turned all the way up. There are other jet ventilators that you can purchase and use if needed. Tracheostomy, typically they already have a endotracheal tube in place. The surgeon, once it's not uncommon for them to nick the balloon of the ET tube when they're making their incision into the trachea, and they will have you pull the endotracheal tube back a ways so that they can get their tracheostomy tube in there. And as you can see with the two sutures, typically they put those superiorly and inferiorly and hold the tracheostomy open with them. Maxillofacial surgery is one that you'll be often involved in the hospital, particularly if you work at a large trauma hospital. A lot of this is secondary to motor vehicle accidents or muggings or assaults that can occur. We used to do a lot more of this in the past as kind of facial reconstruction surgery. Insurance used to be more willing to pay for it, but they've kind of backed away from it and they view it more as a cosmetic procedure than actually a true need. It was often presented that the malalignment of the teeth could cause malnutrition, and therefore we did a lot of the maxillofacials on children, or young adults I should say, to realign, and I have some pictures for that. A couple terms we need to know is that prognathism, that is where the bones are moved forward. That can be either organic or it can be surgical. Retrognathism is where the bones are moved backwards. And again, this can be the posture of the bones from birth, or we can surgically alter them. So typically we do maxillofacial, which is the maxilla, moving it forward, pulling it back, or the jaw the same way, taking the jaw forward or moving it back. Also, you'll see sometimes they'll have the temporal mandibular joint will be causing pain, and we'll do some surgeries on that. They can replace the joint. They can just irrigate it out and do a few procedures there. This is an example of maxillary prognathism that was surgically corrected. They brought, it's called a mid-face advancement, where they move the maxilla out, aligned the teeth for the patient, and you can see that it gives her a more symmetrical facial structure with the surgery. Mandibular prognathism is something we evaluate on our airway checks. We talked about the thyromental distance, and even though they move it surgically forward, it still can present problems for intubation. Again, this provides proper dental alignment and will change the facial structure. Again, here are before and after pictures of a young lady with retrognathism. She had a receding jawline, and you can see that she did the mandibular advancement, so they did a mandibular prognathism and brought her jaw out, and you can see just the change of her facial structure there by aligning the dental structures. This young lady had severe prognathism, and they treated her with retrognathism treatment, where they resected the jaw and brought it back. You can see the significant difference in her, and I just thought it was interesting how she'd kind of redone her hairstyle after her procedure. It maybe felt like she felt more confident in herself, and you can see how having a more normal looking face would make you feel more comfortable in who you are in the public. Plastic surgery in many cases will do that for a large population. So now that we've seen a few before and after pictures of maxillofacial surgeries, it's not a whole lot different than a lot of other procedures you will do. The good news is that the majority of these patients are fairly healthy unless they've had some major trauma. You're typically going to do a nasal tracheal intubation. This may be awake or it may be asleep, depending on the physical status of the patient. You may use a nasal ray tube, which comes over the top of their head, or just a regular endotracheal tube and connect it to the circuit. You'll choose between inhalation or a TIVA technique. You may need an arterial line if you're going to do some hypotensive technique for this type of procedure, or if it's a trauma patient, etc. Typically, the patient's jaw is going to be wired shut, so you need to take extreme care before you remove the tube to make sure that you've prophylaxed some anti-nausea medicine, that they're awake enough to protect their airway. They'll typically have kind of like wire cutters on the bed, so that if they do get sick, you can cut the wires in the mouth and let them spit out whatever comes up. As I mentioned in the fire comments, lasers are frequently used in ENT surgery. The most widely used laser in ENT surgery is the CO2 laser. It allows for precise cutting. It is a particularly fine zone of coagulation, and that it reduces bleeding. It's fairly efficient at vaporizing the tissue, and that's because this laser has an excellent absorption of the far infrared photons. It's often used in the removal of laryngeal polyps and tonsil tissue. Many tonsillectomies are performed with the CO2 laser. Often if there's some sort of hemangioma that needs to be ablated, they will use it. And often some other oropharyngeal malignancy tumors, this laser can be used. And it's usually used in combination with the direct laryngoscopy or the anterior commissure direct laryngoscopy scope. Some anesthetic considerations for laser surgery, and consider that you need to be aware of the potential for fire and collateral tissue damage. These machines generate a lot of high energy. They are a source of combustion. If it's going to be used in the airway, you need to have a special ET tube, as I showed a picture of earlier, that can prevent combustions. Again, when you have these laryngeal polyps, you may or may not need to do awake intubation. You just need to coordinate that with your surgeon. Oftentimes, they'll just use a jet ventilator. If it's going to be a laryngeal polyps, you won't put a tube in there, and you'll just observe and give the oxygen to see the chest rise. Immediately pre-op and post-op, you may use heliox, which is a combination of helium and oxygen that facilitates the movement of the oxygen into the lungs and out of it in small passageways. You may or may not use any neuromuscular blocking agents, and a short-acting narcotic. Remember, whenever you're manipulating the airway with surgery, that they're at high risk for some sort of airway compromise after either immediately or shortly thereafter. And also, you might want to consider steroids to decrease the swelling. Phonosurgery is primarily surgery on the larynx and the vocal cords. It's been around for a while, but its use has been accelerating. It can include microlaryngoscopy or vocal cord injection. I've even seen them do nerve grafting, particularly those patients that have had recurrent laryngeal nerve damage where they have this hemiparalysis. But it's a microscopic surgery that you'll see occasionally. Again, anesthetic management for these patients is similar to other patients. Just make sure you can secure the airway and keep their heart rate and blood pressure within normal limits. Because we're dealing with the head and neck, there is a lot of self-awareness or self-consideration. You look at yourself every day to comb your hair or brush your teeth, and people are very aware of how they look. And so a lot of procedures that we do in the head and neck are considered plastic, but they're often reconstructive. These type of procedures, when they do flaps, they can just do a rotational flap where they maintain the blood supply and rotate that tissue over to another place. They can do a free flap where they take the blood supply and then they hook it back up to another source of blood supply, at a different location, or they could just rotate the flap. And depending on how extensive the procedure is going to be will determine whether you're going to do a general anesthetic or just do local with sedation. Usually these are longer surgeries, and so you have to pick, if you're going to do it in a local, you have to pick the right patient to have it done there. Many times the plastic surgeon, if you're working for them, will have a fee arrangement for each procedure, and instead of billing out for the time, you'll basically have a procedure fee. Sometimes when they're doing a full neck and head reconstructive surgery, they may even do a tracheostomy at the beginning of the case, particularly if they think they're going to need to do it, and you may need to take the patient to the ICU. Blepharoplasty is an eye plastic procedure done, and you can either have the upper lids done or the lower lids done, or both. Typically you have both eyes done at the same time. Usually it's considered a bilateral quad blepharoplasty. There's other terms that can be used for it. It's a routine procedure. Typically it's cosmetic. Sometimes the bags in the upper eyes obstruct the airway, and that's kind of the criteria for it to be done, considered under a medical reason. I've done the majority of these under local with IV sedation. The surgeon will localize the area that they're going to take the tissue out of. Typically, it takes about 30 minutes to do each eye. It's not a long procedure. It's tolerated very well with local and a little bit of propofol and Versed and fentanyl. Here I want to give you some examples of some surgeries, and you can look at them here and see the difference between the bags that they have under their eyes before and after. There are some new blepharoplastic treatments that they actually inject a medicine into the area below the eye that helps firm everything up and helps dissolve some of the tissue that is there. So it may be, as this gains more and more popularity, less surgical advancement here. Another plastic surgery is a facelift. Typically, they're going to pull the tissue back. You're going to do kind of a quad bleph, as well as pull all the tissue back. The incision lines tend to be right underneath the eyelids, around the ear, and into the hairline on the temporal region of the face to hide the incisions as best as possible. Plastic surgeons tend to put their lines in normal facial lines that we have. Again, this can be a long procedure. It can be done under general anesthesia or local with sedation. Oftentimes, again, the plastic surgeon will have a fixed rate for these type of procedures, so they may give you $500, say, for a procedure. So if it only takes them 2 hours to do it, it's a good payday. If it takes them 4 to 6, it's less advantageous. Again, when you do these patients with local and IV sedation, you have to be cognizant of the risk for toxicity to the lidocaine, and be prepared to treat that should the situation arise. Another picture of a quad bleph with a mild facelift for this lady. You can see how it's straightened out kind of the smile lines that are in her, around her mouth. So I mentioned earlier heliox, and it's a mixture of 70% helium and 30% oxygen. Remember, that's substantially, it's a third more oxygen than is normally in the atmosphere that we breathe. That's 80% and 20%. It has a lower density than air or oxygen, and basically it's used to improve airflow through constricted passages. The helium molecule is so small it pulls the oxygen molecule in with it. It may improve airflow through stenotic passages or those obstructed by masses. Typically, you have stridor if people have airway obstruction, and the Heliox helps facilitate oxygenating these patients with that stridor. Another procedure that you may have read about or heard about is facial transplantation. This is a rare procedure. It can be total or partial. This is the first lady that ever had a facial transplant. I'm not sure of her story behind what all happened to her initial trauma, but she was a trauma patient. I think maybe got bit by a dog or something like that. You know, it's a prolonged anesthetic. They're going to take, this is a free flap graft. They have artery and venous blood supplies and nerves that they're going to have to hook back up to make it look real and make the new face function in the way that the patient's original face did. Typically, these are patients that are free of major medical comorbidities because if you have vascular disease or diabetes, the face graft is just not going to be able to survive it. Oftentimes, because they're putting it over the airway, they're going to do a tracheostomy to begin, and you'll just hook your tube up for the tracheostomy and go from there. They'll keep them asleep either with gases or drugs or a combination. Because it's such a long procedure, there is the potential for a lot of fluid shift changes. You may want to put an art line in these patients, maybe not, but it's something to be cognizant of. Here's another gentleman that had a face transplant. It was only partial. You can see they didn't do the forehead on him, but it's kind of a mid-face transplant, and you can see the significant improvement in his appearance from the before and after pictures. And one last gentleman again that had, looks like almost a full face transplant. You can see that there is a major change in his physical appearance with the face transplant, and how functional it is varies from person to person. But I just want to give you an idea that occasionally you might be involved in something like this. These are going to be very long procedures as a rule. And I will end on one last procedure that is not truly a head and neck procedure, but because it's done utilizing the oral pharynx, it's one of the more common procedures that you're going to see or actually perform anesthesia for. And typically these type of procedures are either done with light sedation or deep propofol. Occasionally you may put an endotracheal tube in these patients if it's an emergent procedure, when you're concerned about bleeding and a full stomach and aspiration. Those are all considerations. Just in on kind of a fun note, you'll probably end up doing a lot of these, and you'll probably end up getting one at some point in your life. So thank you very much. This ends my presentation on head and neck procedures. I haven't covered everything that is out there. I know that. There's just a lot of information. And each facility will do things, and each provider will do things a little different. Thank you.